Okay, welcome back, everybody. We have another great lecture for you. A couple quick housekeeping things. At the bottom, if you have any questions, there's the chat and Q&A box. Please use the Q&A box for questions about the lecture content, and if we have time, we'll get to it at the end. If you're in the lobby or if you need to minimize your screen, you can go back out to the lobby and you'll still get credit for attending the lecture as long as you're logged in. So that's another way to view this lecture. And then at the very end, the QR code needs to be scanned with the Arbo OE Tracker app to get credit. But if you forget to do it or if you don't have that app, you will still get your certificate at the conclusion of the event. Our next speaker really needs no introduction. Dr. Christine Sindt is a graduate of The Ohio State University College of Optometry. She completed a disease-based residency at the Cleveland Veterans Administration Medical Center, and she currently is the director of the Contact Lens Service and professor of clinical ophthalmology at the University of Iowa Department of Ophthalmology and Visual Sciences. She holds multiple patents, publishes all over the place, travels and lectures regularly at conferences, both nationally and internationally. There's a lot more to the bio, but we've run out of time for her to give her lecture. So let's please welcome Dr. Christine Sindt.
Thank you. Oh my gosh, I am so pleased to be here today. This is one of my favorite topics, which is post-surgical contact lens fitting. I feel like I cut my teeth on keratoconus, but more recently, my patients are becoming much more complicated. And I think glaucoma is one of the things that we're really learning about as people want to stay functional and they have these surgical situations. We have to figure out how to keep them in contact lenses. And glaucoma is really everywhere. You know, almost 80 million people worldwide suffer from glaucoma. So we are certainly going to run into people that are at various stages of their glaucoma journey. So we're going to talk about scleral lenses and glaucoma in general, but scleral lenses and post-surgical glaucoma cases. This is really a team approach. We need to communicate significantly with the glaucoma surgeon, right? And that communication back and forth is what is going to make for a successful patient. The glaucoma surgeons are always going to be looking at this as how am I going to keep the patient safe? And we're always going to be looking at it as how we keep the patient safe. How are we going to keep that patient seeing with the multiple other things that they have going on? And things that we have learned over time, where to put the tube, how far back to put the tube, what type of surgery to do, what are we looking at the going forward progress of the patient? And we can help them make those surgical decisions based on what we are going to need post-surgical. And some of my most complicated patients at the university where I work, we actually talk about these things ahead of time with an understanding of what everybody's goal is going to be. So communication is absolutely huge. And one of the things I hope to accomplish with today's lecture is increasing our communication amongst colleagues. This is a growing area of education really for everybody. And I'm learning all the time. I phone a friend all the time. We're talking about these things. We're always sharing our best practices. And I'm hoping that you learn something from today, but if you have a best practice that you'll share it back with me as well, because we're going to commit to this learning curve. If you are not committed to a learning curve with fitting these very sick post-surgical eyes, which with the scleral contact lens, you could cause a sight-threatening situation, it's better to refer to somebody who is committed to this learning curve and know the people and the resources. Because unless you do this a lot, there's some things that might trip us up along the way. And I've been tripped up along the way, and I'll show you some of those things as we go through here. Okay. So things we want to consider when we're fitting the glaucoma patient. We want to think about their age, right? Are we fitting a child with glaucoma versus are we fitting an 89-year-old with glaucoma? Because our lifetime expectancy and the end result and how much we need to protect the endothelium and other structures is, we're going to think about it a little bit differently, depending on the age of the patient. You know, what concomitant medications are they using is something that we need to think about, and we'll touch on that in the lecture. Their ocular surface disease, what is the shape of their eye? Are they going to need a tube? Is their endothelium healthy? Are they going to need more surgeries? And are they in an inflammatory state? And we have to manage all of these things. It's not just about the plastic and getting them to see. It's about the biocompatibility of the plastic with all these other things that are going on in the eye. If we look at the literature, if you have not read this article by Dr. Shornack, Vincent, and Walker, it just came out in February, and I'd recommend that you look at it. It's this great review article looking over all the things that have been published on scleral lenses and intraocular pressure. And so the two leading theories about scleral lenses and intraocular pressure, does it raise IOP? Does it not raise IOP? Are we looking at it the right way? The two leading theories right now is that the scleral lens comes down and it lands on Schlemm's canal and it decreases the aqueous outflow, right? So we have an outflow issue, right? We have compression of the tissue, we have an outflow issue. The other thought is that the lens actually has subatmospheric pressure under it, sort of this negative pressure in the space underneath the lens, and that kind of pulls everything forward. It kind of increases the pressure in the eye that way. Now, the question really is do we bioadapt? When we put a scleral lens on the eye, does the eye just kind of figure itself out over time and reaches a level of homeostasis? If we decrease the aqueous outflow, do we stop making as much pressure? Do we bioadapt to the situation that's on the eye? Are all eyes able to bioadapt? Are there people that can and people that can't? Are there situations that can and situations that can't? And so when we look at the literature, and there's been a lot of literature that's been published, and they've looked at it different ways. They've looked at it with different ways of measuring the pressure, the eye care, the tonopen, applanation, a diatom. They look at different size lenses, right? Maybe different types of lenses, different diameters of lenses, all land a little bit differently. People's fitting styles are going to vary, right? I may fit differently than you do. My idea of an endpoint success may be different than yours. We have different fitting things in there. And when you look at all of these, some say it raises pressure, some say it doesn't raise pressure. We've looked, there have been several studies that have actually just looked at the optic nerve over time and sort of diurnal variations of the optic nerve over time based on scleral lens wear. Some people have looked at it longitudinally. Some people just look at it at one point in space. It's very hard to compare all of these studies that are out there. So basically with these studies, it's kind of up in the air. So the consensus right now is we don't really know. Right? We don't really know whether IOP is increased in the short term or the long term. So it's something that we need to be aware of. We do need more study on it. There's no hard evidence one way or the other, but it is something that we should look at. When we have patients, any patient wearing scleral lenses, we should always check their pressure at every single visit when they come off so that we don't miss something subtle. We always need to maintain and look at their optic nerve, look at the whole eye health in general, maybe do OCTs to make sure we're not going to miss anything. But when it comes to glaucoma patients specifically, the question really is can they actually auto-regulate themselves? Do they come back to that period of homeostasis? So while glaucoma raising pressure may not be significant in somebody who does not already have glaucoma, the question is for people that do have glaucoma, are they more vulnerable to IOP changes with a scleral contact lens? We don't know that answer, and so that's where further study needs to be happening. So let's talk about glaucoma drugs in the ocular surface. Glaucoma drugs are mean. They are really mean to the ocular surface, and they build up over time, and the eyes get redder, the lids get worse, the eyes get itchy, and the patient generally becomes inflammatory. And inflammatory situations are very difficult on the eye, but when you kind of capture all that underneath a scleral contact lens, we can end up with even more inflammation. So it's not about changing the fit, it's about managing that inflammation that's happening on the ocular surface. It's estimated that about 60% of patients that use topical anti-glaucoma medications will have ocular surface disease. That's a lot. 60% of patients on glaucoma medications, you will have to concomitantly manage significant ocular surface disease. And they cause a lot of irritation, burning, itching, tearing, and it usually happens within 3 months of wear. And the next point here is really interesting, that people with open-angle glaucoma actually have a lower basal tear turnover rate. They don't make as much tears. And this is important as we move forward and we talk about when you're going to put a contact lens on somebody's eye and they don't have as many tears, they're going to have tear-related complications to their contact lens wear, whether it is with a soft lens or a GP lens or a scleral contact lens, they may end up with tear-related complications. Okay, so how do we manage the ocular surface disease in these patients? We always have to keep in mind that when they hurt, they may not use their medications as regularly because it makes them uncomfortable. So we should ask them about that at every visit. We should ask them when they put their medications in. Are they putting the medications in before the contact lens or after the contact lens is on? Are they using it on a regular basis? We know that when the eye is super dry, that they're going to have more glaucoma surgery failure. So it is up to us to manage the ocular surface disease. So the team approach, again, communication approach. These patients, the drier they are, the more lens fogging they're going to have. And I know people spend a lot of time talking about anterior and posterior lens fogging because it actually makes the patient crazy. It actually makes you crazy. But that is, you really need to be thinking to yourself, why am I having the anterior posterior fogging? And in these glaucoma patients, it's usually the dry eye of the ocular surface disease that's being managed by those contact lenses, or I mean, by those drops. And so it needs, again, the communication. Can we get the patient out of those drops? So here's my pro tip number one for managing ocular surface disease. First of all, recognize it and treat it. These eyelids that you see off to the left here, very common looking inflammatory eyelids for somebody who's been on glaucoma drugs for a very long time. So one of the things that I recommend is after they put in the drop, about 10 minutes after, have them do lid hygiene and wash the excessive drop off of their lashes, off of their lid margins, because that is they don't need that excessive drop on their skin, and that will help them become more comfortable. Consider the use of a topical polysaccharide. The one I like to use, and I have no financial interest in this, but the one I like to use is Zocular, the Zocu Shield. They can get it on the website. They can get it on Amazon. It's not very expensive. They don't need very much. This picture off to the left is the first picture is a presentation. The second picture is 10 minutes after applying the Zocular. The third picture is an hour, and the fourth picture is 2 hours after applying the Zocular. It's a very powerful way to take that inflammation down. And then, of course, if you need to add a steroid to something, I will use Zocular before I add a steroid for the ocular surface disease, because, of course, you may be fighting the steroid, may be fighting their pressure, and you may end up needing more drops because you have the steroid there. So be very careful about steroid use. Also consider going to a preservative-free formula. The BAK is often the thing that is driving this ocular surface disease or driving an allergic or an allergy on their eye. So consider going to a BAK alternative. Again, you can talk about this with the pharmacist. You can talk about this with the glaucoma surgeon if you are co-managing. And then if you need to go to a surgical situation to get their pressure down just because you have to get them out of the drops, this again is where you want to go and talk to the surgeon and you say, look, this person's going to go back into a contact lens when you're done. It's the only way we can get them seeing. Let's come up with a surgical approach and a contact lens approach so that moving forward, we have this patient managed in their post-surgical care. We know that glaucoma induces endothelial injuries. We think that the high pressures actually can damage the endothelium. It can damage those tight junctions. And the medications, we know the longer somebody is on glaucoma medications, the more endothelial loss they have. So we need to consider that our glaucoma patients may be at endothelial risk. And this is something that we should think about prior to fitting. And it is something that we should watch over time. Are we harming the patient with our lens choice, with a hypoxic situation? Are we going to put them into a situation with low oxygen? One of the things that I have been talking about recently, and some of my friends have heard me say this, is we want to make sure that we don't say, I failed the cornea, the contact lens failed the cornea. We should really be thinking about it as, can this cornea support contact lens wear? And if we don't look at that ahead of time, we are not going to know the answer to that question. So think in your mind, can this cornea support contact lens wear? And keep these endothelial considerations. So when we think about the endothelium as a barrier, right, we have two things. We have a barrier function and we have a pump function. And when you have this endothelium, remember the water is going through these tight junctions. It's not going through the cell itself. It's going through these tight junctions. So things that damage the tight junctions, well, if you don't have a hexagonal shape, if you don't have enough of those tight junctions, you're not going to have a good barrier. So anything that mechanically damages the endothelium, that causes the endothelium to fill in, it causes the morphologic changes that we see, that is going to cause a barrier function issue. But chemicals damage from the medication drugs. If we don't have enough calcium, the calcium pump system isn't going to work. If in an area that we're really learning a lot more about, just like we're learning about how the gut biome is super important to control the systemic inflammation, we're also learning how important these antioxidants are in the role of ocular health, ocular surface health, glaucoma. And we're going to be seeing these like things like glutathione, ubiquinol are going to be coming to the market to really help us with this ocular surface and the glaucoma situations in the future, endothelial health in general. We want to think about the pH. The lower the pH, the more difficult it's going to be to pump that water out. We have to think about preservatives. All of these things damage our endothelium. So how do you manage it? When you got to get a specular microscope, you have to know somebody who has a specular microscope, and you should get a pre-fitting imaging of these eyes, not just look at the pachymetry. When you look at the specular microscopy image, you want to look at the number of cells analyzed, because if they've only analyzed 3 cells, you're not getting a great reading on that. You want to look at the coefficient of variation. What does that mean? That means, what are the shape of the cells? Are they all about the same shape, or do you have some cells that are weird shaped and some that are big and small? And because the more uniform the cell size is, even if the cell size is large, but the more uniform the cells are, the healthier the endothelium is, and the more likely it is going to support contact lens wear. You want to look at the cell density, but cell density isn't the end all be all, right? How many cells do you have per square millimeter? So, the common saying is you have to have about 800 endothelial cells per square millimeter, but that's really not true. It's really, you have to look at that cell variation, and you have to look at the hexagonality as well. So what is the hexagonality? That is, are your cells shaped like a hexagon? Because hexagons are the most stable way for cells to stack up next to each other to give you the most surface area of touching, right? Because that pump system is between the cells, it's between those cell walls, it's not through the cells. So the more cell walls you have touching each other, the better and the healthier your pump system is. So you really want to look at that cell variation and that hexagonality. Note that in your baseline, and then watch that over time to see if your endothelium starts to struggle. Okay. So pro tip, I need to move myself out of the way here. So the pro tip here that I'm going to suggest is, 1, your filling solution actually matters. So normal saline, those pink vials, they are a very low pH. They have a pH of about 5 to 5.5. That is much too low for support. If you are worried about your endothelium, you should not use normal saline. Why do we use it? Why have we used it for so long? Because we literally didn't have anything else. So for the first 20 years that I fit scleral lenses, I had nothing but that normal saline. We have now much better things onto the market, and you really do want to consider something like a balanced salt solution. An example of that would be neutrophil. But you can get balanced salt solution just in bottles as well. But neutrophil has the potassium chloride, the sodium chloride, the magnesium chloride, and the calcium chloride, right? It is more balanced, and it is not going to put that osmotic stress onto the surface of the eye. And of course, you want to keep it preservative free, because those preservatives are very nasty to the cornea itself, to the endothelium. You also want to consider your fit. You really do want to go kind of with a minimum clearance over it, so you don't have these giant tear reservoirs. Keep in mind, every time you have a giant tear reservoir, that is a difficult place for oxygen to go through to that endothelium, because the tear film underneath it has less oxygen transmissibility than even some of the plastics themselves. So keep that tear clearance minimal. And in these patients, if you're truly concerned about their endothelium, you want to fenestrate the periphery. That is going to do a couple of things, right? It's going to help with that subatmospheric pressure change that's underneath it. So you won't have a closed system, but you won't have that suction underneath the lens. I think that suction is actually one of the hardest things. This is just a theory. I'm going to have to do studies on it, but I think a suction effect actually puts more stress on the endothelium. And I have seen plenty of eyes where I fenestrate it, I get rid of that suction effect, and their endothelium can function just fine, even in a low cell density state. Okay. So consider fenestrations as well. Not fenestrations that necessarily go into the optics, but fenestrations in the flange of the lens. Okay. So what do we really need to know what type of surgeries we are dealing with, right? There's a bunch of different surgeries, and I'm really only going to talk about here the ones that really affect our contact lens fitting. So I'm not going to talk about MIGS or the microtubes, because they don't affect our contact lens fitting that I know of right at this moment. So I'm going to talk about the ones that are really more obvious, and that's really the trabeculectomies, the blebs, and the tube shunts, the patch grafts. Now, when I talk to doctors, I will frequently say, they'll say, well, I have a patient with a bleb, and I will always stop you and say, bleb or patch graft, bleb or patch graft. What are we talking about here? Because we really do need to know the difference, because it makes a huge difference in how we approach that eye. Okay? Blebs are both are tricky. Both are very tricky, but a bleb is much trickier than a patch graft. Okay. So what is a bleb? A bleb is where we make an incision into the anterior chamber. We make an actual hole into the anterior chamber, and then we drain the fluid into this subconjunctival space. It gives a dramatic amount of IOP lowering. So my surgeons will use a trabeculectomy if they need to get the pressure down fast, right? If we have got to get that pressure down, if it's emergent, they will do a trabeculectomy. Now, every surgeon has their own preferences. So I have a newer surgeon to my team that I was talking to, and they're like, I prefer trabeculectomies. I feel like I just get the pressure down faster, and that makes me happier. And I had to say, hey, doesn't make me happier, right? I'm going to have to deal with this. This is much more difficult. So he said, oh, I wasn't aware of that. And maybe it sets us all into a sort of a different thinking pattern. So it is good to talk to the surgeons again. I have said that several times now. Here's the thing about trabs. You never really know what you're going to get. So you might get this low, shallow, flat, broad trab. You could get a super high trab. You could get one that's back. You could get one that's right on the limbus. You could get trabs that are overhanging the limbus. You can get trabs like this one in the lower right corner here that are super thin walled, right? And you're thinking, oh my gosh, that thing is going to just pop, right? I'm going to look at it, they're going to blink and it's going to pop, right? And so we have to be aware that the morphology of these trabs is very complicated. And that when you have a complication, you're looking at something like this, a blebitis, right? Or endophthalmitis. And you always need to be looking for these trabs. Are they leaking, right? Paint a little fluorescein on and see if we have any place where that trab is leaking out. Now, early on, right? This is in 1981, there were these publications that were reported about how contact lens wear was the absolute worst thing that you could ever put on somebody that has a bleb. And our ophthalmology colleagues have really hung on to this, right? And they are taught at an early age, do not put a contact lens on a bleb. Do not, right? And that's probably true if you're not doing the contact lens in the hands of a capable person, one of us that know how to handle these bleb situations. Okay. There was another, this is in 2001, another report that came out that said, contact lens wear is a huge risk factor after glaucoma filtration surgery, after putting on these blebs. Don't wear contact lenses. So again, published in very high-end journals, don't do this. And so again, our colleagues are like, no, don't put contact lens on it. And they will push back at you. But of course, your patients are saying, but I can't see, and they're like, and the glaucoma doctors are like, but you're not blind. And the patient's like, but I can't see. And we're like, I could help with the contact lens. Again, communication is required. So since then, there's been also a bunch of publications that have come out that said, contact lenses actually can be very successful at post-surgical and don't necessarily have to carry a huge risk with them. And in these studies, what I want you to note here is that these studies were primarily done on gas permeable contact lenses, and they've had very low rates of complications. And then Dr. Barnett and colleagues published this poster looking at blebs and contact lens wear. And to note here, they had much lower complication rates in the gas perm. There was much more success with the gas perm wearers than there were in any other type of contact lens, including scleral lenses. So my take-home point here really is, if you can get them into a gas perm lens, have them wear a gas perm lens, because scleral lenses are going to have inherently certain complications. One is that blebs are usually really close to the cornea. So you're going to have a situation where you have plastic rubbing on a very thin wall or coming into contact lens with a very thin wall. And when you have any rubbing at all, that could lead to a situation where you get an erosion. Okay. I want you also to consider that a bleb breathes in and breathes out. It will change size significantly throughout the day. So when you have you think the bleb looks good, but then the bleb gets bigger because there's an increased aqueous output. It could start moving around the edge of the lens, and you can get that rubbing. And so blebs are known to erode faster than tubes, and they have more elevation changes than tubes. So you really need to be thinking what is going to be in the best interest of this patient, and it's generally going to be a gas perm lens. If you're going to fit a gas perm lens, you should think, I'm going to fit this smaller and I'm going to fit this steeper. Now, you may be thinking, well, I'm just going to put them into a soft contact lens, but soft contact lenses really have one of the biggest risks with blebs, because the edge of that soft contact lens comes up and it is going to rub right into that edge of that bleb, and the edge of the soft contact lens may actually cause a laceration into the bleb. So I would avoid those if you possibly can. So just to remember, here's a little GP fitting tip here, that flat lenses ride high and steep lenses ride low. So if you possibly can, you want to go a little bit smaller and you want to go a little bit steeper than you would normally fit, because you're not looking for that classic lid attached fit that's held up with the eye. You want a lens that's going to just chronically ride a little bit more. You do want to make sure that it has tear exchange underneath that contact lens, and therefore you want to keep it away from where that bleb is. You don't want it where it's moving excessively and banging into that bleb. Okay. You want to watch when you're fitting this, you want to watch for erosions or dellins. And so if you have a lens that's riding low all the time, and you have a bleb that's here that's high, and you have a contact lens here and the eyelid's blinking over, you may, and they have a low aqueous, or they have a low tear film, because we already said these people have low tear film and ocular surface disease, you may end up with a dellin or a drying area that's between the contact lens and the bleb. So always stain, and then you need to manage that dellin or the erosion. Now, you may get a dellin or a dry area right next to the right next to the bleb in the absence of a contact lens at all. This person may end up with a dellin. So watch for this while you're fitting and after you're fitting. Okay. So let's turn to glaucoma tube shunts here. And in the glaucoma tube shunts, there's really two types, the Ahmed valves and the bar belts. And your physicians are going to have preferences of one over the other in which they prefer. I have noticed in my surgeons, I have noticed a shift towards using the Barvelds more, but I certainly have a lot of patients that are in the Ahmeds as well. The advantage of a tube shunt is that it's a little less risky, but it also does not lower the ultimate IOP is not quite as low as with a bleb itself. So again, that's a balancing act that the surgeon is going to have to choose. But overall, it is going to be much easier to fit somebody with a tube shunt. I just want to point out that this patient has a Barveld inferiorly and an Ahmed valve superiorly here. Same patient, same eye. Okay, what are the tube shunt risks? Well, one, hypotony, right? If the eye pressure is too low, you should not fit that eye, right? It's like fitting a somewhat deflated beach ball. And so when you put a contact lens on a deflated beach ball, it's really not going to be fit or not going to fit quite right. And you can chase that fit around and you can spend a ton of money trying to get that person fit. But really, if the pressure is too low, you got to get them back. They need to get that pressure up. Now, remember, when they have tube shunts, you don't want to fit them too early on because the tube shunt has to open up. And so the pressure may be high. And then when it opens up, the pressure may go down and then it will equalize out. So you don't want to fit too early in a tube shunt. So you're going to be really looking at a couple of months out from fitting a tube shunt. You want to look to see if the tube is exposed. Now, this image in the lower right-hand corner, this is a patient who came to me. I had not fit this patient, but the tube had eroded naturally. So you need to watch for that. And then, of course, the tube in the eye goes right, under the cornea, and you may experience, again, as we mentioned before, endothelial cell loss. You will always get endothelial cell loss when you put a tube in the anterior chamber. And so you want to look for that. You want to watch it. You really want to do good endothelial evaluation prior to fitting, because you may end up with corneal decompensation in those areas, microcystic edema, the epithelium may come off in those areas. Know the type of patch graft you're working with before you fit. So early on, pericardial tissues, it's very rarely used anymore, but pericardial tissue was used. And pericardial tissue is kind of like wet tissue paper. And people even can just blink it off or will erode. Pericardial tissue just seems to erode on the eye. And then really everybody switched to scleral tissue. And now we're seeing this shift over to using corneal tissue. I prefer corneal tissue. And, I've gone back and I've talked to my corneal surgeons on how much I prefer the corneal tissue. Why do I prefer corneal tissue? Because the scleral tissue, when you use a scleral patch graft or use scleral tissue, it gives you sort of this rectangular shape of tissue that goes over the tube. And so you end up with these really weird and extreme curvature changes. Whereas when you use corneal tissue, it's a much gradual and smoother transition. So it's going to be easier to vault. It's going to be easier to create space over the tissue. The corneal tissue is much smoother and it's much more regular. So from my perspective, I prefer the corneal tissue. It's a very sturdy tissue to work with. Okay. Now, if you're going to put a soft contact lens on a tube, I would not advise a soft contact lens on a bleb. If you're going to put a soft contact lens on a tube, you want to go with a low modulus lens. Okay. And so I will frequently use, if I need to, a daily disposable lens. You want to use something that's thin. I don't necessarily use a high decay material. For example, Acuvue Moist lens has a much lower modulus than an Acuvue Oasis lens. So sometimes I can get the draping better over the tube. You want to avoid a soft contact lens. If you have a really high elevation, you want to make sure that there's no rubbing right at the edge. So a soft contact lens isn't necessarily safe. Where are you going to see staining with a soft contact lens is right at the edge of the lens. And again, if you have a high area and the lens butts into it, that's where you're going to get rubbing, movement, and sort of a laceration, if you will. Okay. Another option for fitting a tube is to vault over it or to notch around it. So if you're going to notch, this is not a tube here in these pictures, but it gives you the idea. If you're going to notch around it, you want to identify the area, you want to outline it with a Sharpie marker onto the patient's eye, and then you can use a Dremel, you can use a nail file. You can put a polishing pad on your Dremel if you don't want to use the grit stone. And then you can just notch out that area that you've identified. And then, of course, make sure you polish the edges. You don't want to have, and you can use the polisher on your Dremel tool. You can use a bowl polisher if you happen to have one of those. But you want to have a very round and smooth edge. You don't want to have any square points, anything that could rub on the eye. If you're going to create a notch, you want to make sure you do it appropriately. Here, you only remove enough plastic into the flange area. The closer you get to the optic portion or past the limbus, the greater the likelihood that you're going to suck air in underneath that lens. And then you can actually form a Dellen under the lens if you have a non-mobile bubble. So a pro tip here would be to insert the contact lens. If you're getting a little air in, you can insert the contact lens with a viscous gel, and it kind of keeps that air out from underneath that contact lens. Now, here's an example of a poor tube alignment with a notch. So I would recommend notching, taking a little off. It's like adding salt to a soup, right? You can always take more tissue or more plastic off. You can't add plastic back onto the lens. So you want to just keep taking it off to get to the right place. Now, if you don't have the notch has to be put into the eye and into the correct place. So you either need to have a ballasted lens so it goes to the right place, or you need to make sure that it locks in. Here's a much more eloquent fit by Dr. Denier, where he notched out. In this case, he did a bleb, and you can see that little bubble underneath there, because it's very easy to draw air in underneath these situations. But you do want to keep it close to, but not touching the affected area. If you're too far away, you're going to run the risk of that Dellen formation, that drying formation underneath that. So what if you decide you're going to vault? I'm not going to notch, I'm just going to go up and over. Okay, so let's talk about the anatomy of the tube here. So a tube goes into the eye, but it always creates this arch in. And when you put a contact lens on top of it, the haptic is going to land really at the apex of that arch. So if your haptic comes down too tight and presses on there, you will create a plastic squishy tissue, plastic sandwich, and the squishy tissue never wins in this scenario. So you actually have to create extra vault over that so that you aren't putting any pressure on the tube at all. The rest of the lens will take the bearing, but you want to vault with no pressure over that tube. So how do you do this? So before you start the fitting, you're going to want to use your OCT. You're going to want to do it longitudinally like that and identify that high part. Where's the highest part of the arch? And then you're going to want to do it cross sections over that tube and really take multiple measurements. And how thick is that? This is a scleral patch graft, and you're going to notice the ultrasound dense area over the tube is the sclera, and the lighter area is actually the conjunctiva. And so that conjunctiva is going to keep remodeling over time. So you then, when whatever lens that you're using, whatever software you're using, you want to then create extra vault over the tube. That'll be about 300 extra microns, maybe 400 extra microns over that tube. And what happens is you then put it on the eye, and you're going to get, when you do to the dispensing, you're going to get some leakage that's going to come in around the tube. Do not let that freak you out. It's absolutely fine. What's going to happen over the next couple of weeks is the conjunctiva is going to remodel itself and fill in underneath that tube area there. So you're not going to get constant leakage underneath that. You may initially suck in some mucin. Maybe they're on a steroid, so you're going to suck in some steroid particles underneath it. Just tell the patients that's going to happen, and they're just going to have to live with it for a couple of weeks. This is not the worst thing. A little debris under the lens is not the worst thing that's happening in their life. They're just going to have to kind of suck it up for a while. You can try using a gel in the bowl to keep it out, but that conjunctiva will remodel. Your ideal fit is going to have no hyperemia and no compression. This is an eye with actually 2 tubes in it. Now, this particular patient of mine has been wearing this vaulted lens for almost 10 years and has had no problems. Prior to that, he was in a lens where both tubes eroded. So then after the patient is wearing the lens, so step 3 is you always want, again, to measure that distance from the tube to the back of the to the back of the contact lens itself. You will notice at first that you're going to have a little bit of an increase in that area there. And you're always comparing it to whatever your baseline measurement is. If you start to see that it's decreasing, then you need to watch the patient more closely because you may be heading towards tube erosion. If you get the patient, if you see thinning, but you get the patient before the tubes eroded, you can take them out of the lens and that area will actually fill in and thicken up again. The conjunctiva will migrate again. So here is examples of looking at tube erosion. The top one here is where you see there's just a little erosion there, and the bottom one is where you have a full tube erosion there. So you watch for these tubes. And I have the patient be followed every 3 months. I follow him on the 6 months, and I have the glaucoma surgeon follow him on the opposite 6 months. So the patient is seen every 3 months. Okay, so one final thought here is, well, I think we're cruising through this pretty quickly. One final thought here is many of these eyes are compromised in other ways. And I mentioned that a plastic squishy tissue plastic sandwich, the squishy tissue never wins. So these eyes will often have, especially in trauma cases, will often have these scleral sutured IOLs, and you may not even know that it's there, and you may not even see any elevation. So while in this particular patient, I knew that the patient had that scleral patch graft superior temporally there, and I was watching for that and controlling for that. I did not know that the patient had a scleral sutured IOL and superior nasal. You can see in this picture that it's quite a lot of hyperemia there, and we actually ended up eroding the IOL knot underneath, and that came up through, and the patient actually had to be taken back to the OR and have a piece of patch graft placed over that. Ended up having a corneal tissue placed over that area, and then the patient had to come back in and be refit. So again, communication is really huge. I would recommend going back to your surgeon and say, you know what, I need to know if you're going to put any other hardware in this eye. I need to know if this is a scleral sutured IOL, because this is a topic that really hasn't been talked about. So all right. So I think we're going to open it up to questions. I know I went fast there. I was a little concerned that I didn't have enough time, but I think we have time for questions. So Dr. Inslee, let's.
Yeah. So we have about 10 minutes. So if anybody was holding on to some questions, feel free to shoot them through. We definitely have some time. One question that was asked is, which gel do you recommend for insertion?